Okay, it's Mari McInerney here from Croaky again, talking at the Oceania I've done it again, Tobacco Control Conference in Perth, and I'm talking to Kirsten Corban, who is from Alfred Health, and what's your title there?
My title is Lead for Population Health and Health Promotion.
And you presented yesterday at a workshop here, and it was particularly focused around disadvantaged communities and what we can do about stopping smoking in those groups.
Yep.
But can you tell me what you were talking about? What was the project, or not the project, but the program that you've implemented there?
Yeah, I was talking yesterday about Alfred Health being a major metropolitan health service within the city of Melbourne.
Mm-hmm.
And our approach to how we become a smoke-free environment, but more particularly around how we've supported people who smoke or people who are nicotine dependent, around offering them support to manage that dependency and hopefully to quit smoking. So we've achieved a systematic organisation-wide change there. It's taken us quite a long time, but I think it's something that's achieved some really very strong results, and we're happy to share our approach.
Before we get to the results, how did it come about? What drove it?
Yeah, well, we were the first major metropolitan health service in Victoria to go totally smoke-free. So we did that in May 2008. Previously, we had designated smoking areas in place, so people had to move to those areas if they were to smoke. So in 2008, we said no smoking anywhere within our property boundaries. We needed to move people beyond the perimeter. And when you do make improvements around a smoke-free environment such as that, we know some people quit smoking, which is a great outcome. Some people continue to smoke but smoke fewer cigarettes, which again is quite positive, and then some people continue to smoke and just moved the location of where they smoke. So we made that change. We did that reasonably well. We did it in a very short space of time, but an area for weakness in our organisation at that time was around our clinical management of smoking and nicotine dependency. We weren't at all strong in that area.
So why was that, and how did you approach that?
In terms of why it was, I guess there's lots of different theories about that. We're a very high-performing health service. We're very strong in acute care, particularly. So I guess when we talked a lot to our clinicians, we had lots of clinicians saying that they were very comfortable doing some very high-end procedures. Lots of people happy to transplant lungs, transplant hearts, talk about amputating limbs. But we were really very surprised. I guess we had lots of medical staff and other professionals as well saying they're not comfortable having the conversations about smoking. It seemed to them to be a very sensitive topic and one that they didn't feel they had the skills to have, and not necessarily that patients wanted that conversation to be had with them either. So we needed to change that process, develop strong clinical leadership in pharmacy in the end, and really emotionally compel health professionals to have those conversations.
So what did you implement? What sort of things?
We've implemented a pharmacy-led clinical model. So we've actually credentialed 130-something clinical pharmacists across Alfred Health to systematically identify those people who smoke, to undertake an assessment of the level of dependency that those people have, and then they use a treatment algorithm to offer support, and nicotine replacement therapy is one of those offers. So pharmacists can actually initiate NRT now rather than having to wait for medical prescriptions. So we've got much more ready access for those sorts of supports to our patients, and we've got all forms of NRT. And then we've extended even beyond that brief intervention model to start looking at supporting people at the point of discharge if they are making a quit attempt, and we've got some clinic-based options for people who are more complex as well.
What was it that made it be a pharmacy-led intervention? Yeah,
look, I think we needed to establish clinical leadership with a discipline that saw every inpatient routinely. If it was going to be a brief intervention model, it's going to be absorbed within existing interactions and not be a model that's going to call on extra dollars. So for us, that meant it was going to be medical, nursing or pharmacy. Other allied health disciplines don't routinely see every patient. So the fact that pharmacy is already involved in dispensing nicotine replacement therapy, if it was prescribed, meant that pharmacy was already going to be involved. And pharmacy were prepared at that time to take that lead. So for us, it was very exciting. It was around 2011 or so that was actually decided, and as soon as pharmacy took the lead, we had medical saying don't do it without us. We had nursing saying we want to be involved. We had all the other allied health disciplines wanting to stay consistent and be on board as well. So for us, that was outstanding. We've got a very high-performing pharmacy department who have really made this work.
And so how is it different there then for a patient? What happens that wouldn't happen in all other places, but certainly didn't happen there before?
Yeah, for us, previously, a small number of our patients would be asked about their smoking. When we've measured this, it was around 14% of the time that we'll be talking to patients about their smoking and offering them any sort of support. Now we perform beyond 90% consistently, so every patient almost who comes to Alfred Health will be asked about whether or not they smoke, and if they do smoke, there'll be a little bit more questioning to understand the level of dependence, and then all of our clinicians systematically, without any judgment and without excluding anyone from that process, will offer support. And that offer of support can be quite a simple offer. Understand that you smoke, you can't smoke in this environment, we'd really like to help you with that. And it can include things like nicotine replacement therapies that will help somebody manage their dependency and be a whole lot more comfortable.
And you said it's been very successful, in fact award-winning, I think. How do you measure that success?
We measure it in that we set ourselves key performance indicators. So we try to look at process measures around how routinely we ask people about their smoking, how routinely we offer that support. And we've also got a number of opportunities to start looking at the effectiveness, so the number of quit attempts that result from that. And then we've got examples in things like our outpatient smoking cessation clinic, where we actually measure cessation rates, and we perform very highly.
And can you say what those rates are, quit attempts and cessation rates?
There's lots of ways to measure them, so it's quite hard, I guess, to do it in a way that's comparable, and it depends on the length of time since somebody's quit. But we've got a very complex population in that group, and we can perform sort of high 30s or even up to 42% cessation in that clinic, which is a very impressive result. So that's something that really excites us. It reinforces our organisation's commitment to continuing around this sort of work, and we don't want it to be seen as something that's unusual or brave or very different. We want this stuff to become normal and standard practice for everybody.
So you've got some resources, and I think there was a video that you were talking about. And how can people find out more about it?
Yeah, we do have a video. We've got a campaign called Start the Conversation, so starttheconversation.org.au. And that was around us doing a lot more work with health professionals around what the barriers might be to them having the conversations with patients about smoking. It certainly isn't a lack of knowledge or an evidence type barrier. We don't need to load up health professionals with a whole lot more evidence. They already know smoking is bad, they know quitting is good. So we needed to actually emotionally compel our health professionals, for them to realise that patients want the conversations to be had. It can be as simple as a 1-minute conversation within your existing interaction, and you don't know which patient is going to take that on board, and actually, could be quite life-changing for them. So,
and what's the emotional trigger for the clinicians?
We've used in this 4-minute video, we used real clinicians and 4 real patients as well from Alfred Health, and there's no scripts at all in that video. It's highly authentic, and those patients tell real stories about when somebody actually took the time, that had that brief conversation and showed some faith that that person would be able to quit, and they're all success stories, I guess, in that video. So it actually, I think it's something I would encourage people to have a look at. It is really very emotionally compelling. That's won some awards, and it's had a very big reach.
And where to now?
Where to now? I think we've got some big ideas, I think, about pushing even harder around some of this work. So we want to do even better prior to planned admission. So quite a significant proportion of people who come to an acute health service are known before they come. They might be waitlisted for elective surgeries or similar. We're doing some work in that area, but we want to get a whole lot better at helping people quit even before day 1 of admission. That'll achieve a whole lot stronger outcomes for them and for health services overall.
Great, thank you very much.
Thank you.